A very good evening, ladies and gentlemen. We now witness the arrival of our distinguished invitees into the Lotus Ballroom here at Shangri-La in order to formally commence the International NASH Day 2024, hosted by Sri Lanka Society of Gastroenterology, supported by P&G Health. And in keeping with tradition, let us commence the day's proceedings with the lighting of the traditional oil lamp. And in order to do the honours, we cordially invite Dr. Asela Gunawardena, Director General of Health Services, Ministry of Health, Sri Lanka; Professor Madhunil Niriyalla, President of Sri Lanka Society of Gastroenterology; Dr. Nandana Dinamitra, Joint Secretary, Sri Lanka Society of Gastroenterology; Dr. Sumedha Udumalagala, Consultant Gastroenterologist, Teaching Hospital, Kalutara; Dr. Chatra Piyaratna, Consultant Gastroenterologist, National Hospital, Kandy; and Mr. Ushan Pires, Associate Director, Emakemi NB Salon Limited. And now, we'd like to invite the following dignitaries to please join us on stage. Dr. Asela Gunawardena, Director General of Health Services, Ministry of Health, Sri Lanka; Professor Madhunil Niriyalla, President of Sri Lanka Society of Gastroenterology; Dr. Nandana Dinamitra, Joint Secretary, Sri Lanka Society of Gastroenterology; Dr. Chatra Piyaratna, Consultant Gastroenterologist, National Hospital, Kandy; and Dr. Sumedha Udumalagala, Consultant Gastroenterologist, Teaching Hospital, Kalutara. Ladies and gentlemen, please rise for the pride of our nation, the national anthem.
Sri Lanka Mata, Appa Sri Lanka, Namo 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 Mata, Sundara Sri Dharini, Surani Ati Sobhamana Lanka, Ranya Ganaya Mekamal Valakuru Jaya Bhumiya Ranya.
Thank you. Please be seated. Once again, a very good evening, ladies and gentlemen, and a warm welcome to all of you to International NASH Day 2024, hosted by Sri Lanka Society of Gastroenterology, supported by P&G Health. Now, ladies and gentlemen, talking a little bit about today. Today is a day to raise awareness on non-alcohol related fatty liver disease, which is also known as NAFLD, and it's a more advanced form of non-alcohol related steatohepatitis, NASH, which affect more than 115 million people across the globe. And as the evening unfolds, ladies and gentlemen, we will discuss more about the silent but the significant threat of fatty liver disease in the country, as well as the dedication of our medical professionals in combating these diseases. So, ladies and gentlemen, let's delve into the complexities of this disease, explore advancements in research, and also talk more on the progress being made in the field of treatment as we pave the path towards a healthier future for all. And now, in order to formally welcome you all this evening, we'd like to invite a professor in gastroenterology at the Department of Medicine, Faculty of Medicine, University of Kelaniya, Ragama, Sri Lanka, who's also a senior hepatologist at the Colombo North Center for Liver Disease, Faculty of Medicine, University of Kelaniya, Ragama, Sri Lanka, and the president of Sri Lanka Society of Gastroenterology. Ladies and gentlemen, please join me in welcoming Professor Madanil Niriyalla to formally welcome you all this evening.
Good evening. The Chief Guest, Dr. Asela Gunawardena, Director General of Health Services at the Ministry of Health, Sri Lanka, officials and the council members of the Sri Lanka Society of Gastroenterology, distinguished guests, colleagues, ladies and gentlemen. It is my great pleasure as the President of SLSG to warmly welcome you all to our International NASH Day celebrations of 2024. As you know, the Global Fatty Liver Day, which falls on June 8th, aims to raise awareness about the serious health issues of non-alcoholic fatty liver disease, or NAFLD. Awareness efforts like today's event are crucial, as NAFLD is often overlooked non-communicable disease despite its prevalence and the potential to cause adverse cardiovascular and liver-related outcomes. Regrettably, NAFLD, or MASLD as it's referred to now, receives far less attention than its closely associated metabolic conditions, diabetes and obesity, even though these conditions commonly coexist. We hope this event will change perceptions and attitudes towards NAFLD among healthcare providers and policymakers in our country. Increasing the understanding of this impactful disease is vital for improving prevention, diagnosis, and the treatment efforts. I thank our esteemed chief guest, Dr. Asela Gunawardena, for his support and presence today. Thank you, sir. I'm also grateful to all of you for joining us on a Saturday evening to learn more about this important public health issue. We have two leading local experts who will share their invaluable knowledge and experience regarding NAFLD or MASLD. I'm confident their talks will stimulate great interest and motivate decisive action to combat this widespread disease in our communities. Thank you.
Thank you very much, Professor Madhunil Niriyala, for setting the stage for International NASH Day 2024. And now, ladies and gentlemen, please join me in welcoming our distinguished chief guest this evening, Dr. Asela Gunawardena, Director General of Health Services at the Ministry of Health, Sri Lanka, to address you all.
Good evening to all of you. The President of Sri Lanka Society of Gastroenterology, Professor Madhunil Niriyala, the President-elect, Dr. Chaturanga Kapetiagama, the Consultant Gastroenterologist, National Hospital of Kandy, Dr. Chatura Lakmal Priyantha, Consultant Gastroenterologist, Teaching Hospital Kaluthara, Dr. Sumedha Udumalagala, Joint Secretaries Dr. Nandana Dinamitra and Sachintha Tilakaratna, and all past presidents, all council members, members of academia, all the professors, consultants, ladies and gentlemen. First of all, I would like to thank the Sri Lanka Society of Gastroenterology for the invitation they extended for me so that I could be a part of this proceeding in this evening. It is a pleasure and a great honor to stand before you this evening. Your college is dedicated to the development and promotion of gastroenterology and hepatology and employing a multidisciplinary approach to achieve excellence in clinical practice. It is evident by this initiative taken by all of you seizing the opportunity to raise awareness on the concealed global epidemic that is on non-alcoholic steatohepatitis as we commemorate International NASH Day today. This often underdiagnosed and underreported condition which can lead to cirrhosis, liver cancer and even liver transplant later stage affect more than 100 million people worldwide, and this number is expected to increase more than threefold by the end of next 5 years. One of its major risk factors is obesity, and the Sri Lankan population has shown a rising trend in its prevalence over the past few years. The two more major risk factors, the type 2 diabetes and the hyperlipidemias, are non-communicable diseases which account for the majority of disease burden in Sri Lanka, as well as the majority of deaths and disability-adjusted life years of Sri Lanka. While we have taken measures to integrate early detection of NCDs in healthcare service delivery, the limitation in capacity to identify, manage, and track patients over the time has led to a lack of continuous, coordinated, and patient-centered NCD care. The effective management and control of NCD require a life cycle approach with a strong focus on preventive care from primary care level. Raising awareness about non-alcoholic steatohepatitis should focus on the behavioral habits of people which we are able to change to prevent the disease. As a college, I earnestly request from all of you, please come forward and do this endeavor, because usually what we see in the media is not what we need. The people who comes and tell in the media is mostly not the consultants or the specialists. So there are a lot of specialists right now in the media channels. So it is your duty, I think, as a college, please come and help us. We will give you a chance to come to the media and tell us, because this is going to be a huge problem in future in Sri Lanka. Eating healthy, being physically active, and staying at healthy weight can slow down, stop, or even reverse this condition. What we must address the effect of modern lifestyle choices and dietary pattern that have spread from developed countries to low middle income countries such as Sri Lanka. As Sri Lanka commemorate International NASH Day in 2024 with 70 other countries in the world, I believe it is the perfect occasion to acknowledge the need to reach out our local communities. We must educate and empower our people to make healthier life choices. We must raise awareness about the disease, its causes, symptoms, potential complications, and the importance of early diagnosis and management. NASH remains relatively unknown among general public despite its growing prevalence. One of the best ways to achieve community engagement and empowerment is by establishing productive collaborative effort between Ministry of Health and the Society of Gastroenterology. Approximately 75% of the people with liver disease are diagnosed at the stage when it's often too late for treatment or intervention. As such, Ministry of Health endorses active engagement in scientific study related to this field in order to facilitate the growth of evidence-based medicine, conducting such while in keeping with ethical practice for the greater benefit of all people. I hope this scientific discourse of this evening inspire the minds of those who are present here today to pursue means of bridging the gaps that exist in the Sri Lankan healthcare delivery in addressing the needs of those who are at risk and already affected by the adversity of non-alcoholic steatohepatitis. Before I conclude, I must appreciate the initiative of Sri Lanka Society of Gastroenterology to commemorate International NASH Day in 2024. I am certain that the proceeding of this evening would be a very productive one. Thank you.
Thank you very much, our chief guest, Dr. Asela Gunavarthana, for the sentiments expressed. And now, ladies and gentlemen, we move on to a special presentation, and it is by a senior fellow, clinical fellow of Adam Brooks Hospital, University of Cambridge, from 2016 to 2017, who was also a senior clinical fellow at Guy's and St. Thomas's Hospital, London, from 2017 to 2018. And he was also consultant gastroenterologist at the teaching hospital in Anuradhapura from 2020 to 2021, and is now the consultant gastroenterologist at the National Health Hospital, Kandy, since January 2022. His special interests are in non-alcoholic fatty liver disease, cirrhosis, liver transplant, functional GI disorder. And in order to present to you the silent threat, the growing burden of fatty liver disease in Sri Lanka, ladies and gentlemen, please put your hands together and welcome Dr. Chatura Lakmal Piyaratna.
Good evening, ladies and gentlemen. So first of all, I must thank President and the Council of Sri Lanka College of Gastroenterology. And I'm delighted to be here because my audience consists of teachers, my senior and junior colleagues, and even my trainees and my ward staff. So my task is during next 20 to 25 minutes to talk about the silent threat, the growing burden of fatty liver disease in Sri Lanka. So I will talk on these topics. So we all know that the fatty liver disease is an epidemic of new millennium. So it is what we thought was, it's a new consequence of the obesity epidemic because it poses a significant threat to affected individual and to health system. Already we know that the health system is strained by the growing burden of the chronic non-communicable disease in this economic crisis. So when it comes to the NAFLD definition, we all know that it is a spectrum ranging from benign non-alcoholic fatty liver or simple steatosis to the more severe form of non-alcoholic steatohepatitis. So this entity is characterized by hepatic steatosis, or fat deposition of more than 5% in your liver without an identifiable secondary cause. So in 2020, an international expert consensus has come out to introduce the term MAFLD, what is called as the metabolic dysfunction associated fatty liver disease, in place of NAFLD, because what the majority thought is MAFLD would be better represent the disease process than the NAFLD. So the MASLD is defined by the presence of hepatic steatosis with at least one of the 5 cardiometabolic risk factors like BMI more than 25, diabetic state, hypertension, or the altered lipids. So MASH is a subdivision of MASLD in which the inflammation and the cellular injury are present, as evidenced by elevation of aminotransferase, which is, we call it as a transaminitis. So hepatic inflammation may be histologically indistinguishable from alcohol-associated steatohepatitis. So you can see that what is the natural progression. So if you somebody diagnosed with the steatosis, maybe by incidentally on ultrasound, or if there's any blood test abnormality, 1/3 of that progress into the state called the steatohepatitis. So what we know is that about 1/4 of steatohepatitis will lead to cirrhosis, and the 7% would progress to the HCC. So you can see how the disease is progress. So this is actually the subclassification of steatotic liver disease. So the one spectrum is metabolic dysfunction associated liver disease, which we call the MASLD. And there's a subset of people who have got same clinical, the risk factors with excess alcohol. So now the term is for that group is MET-ALD. So that's a metabolic associated dysfunction and the alcohol, excess alcohol intake. But there's a separate group which can give rise to the alcohol related or the alcohol associated liver disease, which calls the ALD. And there's a subset which does not include to the other category, which calls the specifying the non-specific the SLD. So which comes the drug-induced liver injury and the miscellaneous causes. If you can't put any patients into those steatotic stage, we categorize them as cryptogenic SLD. So actually, nomenclature, there's an evolution. Earlier in 1850, so the pediatric group that they have identified the population of obesity, which we then defined the term called fatty liver disease. After 30 years, after a few years, that they have introduced the term called NASH. And then after a few years, the NAFLD came into the medical practice, and a few years back only the term of MAFLD, which is the metabolic dysfunction associated fatty liver disease, is come into the our practice. And the last year June, the MASLD has given the term for this to explain this kind of people with these risk factors. So what we know is in hepatology, so there is a disease called, in a few years back, we call it a primary biliary cirrhosis. But in 2016, the name has changed to the primary biliary cholangitis, which we were focusing on their underlying pathophysiology. So like us, the MASLD has come into the liver group. So what is the prevalence? Our DG said that more than, half of our global population by 2040 leading to, affected with this disease entity. So it's a huge burden. So in 2022, the Lazarus et al. Noted that the majority of world nations underprepared to handle the impending epidemic, because this is an epidemic, and its complication. So the theory behind is it may be due to the the life expectancy of the global population rises and the age at diagnosis of NAFLD falls. So then the burden of the disease and its complication will escalate significantly, because it may be due to the advancement of the the diagnostic tools. So what are the data from Western countries? In US, the MAFLD prevalence ranges between 10 to 50%, while worldwide prevalence of 60 to 35%. So you can see the graphs that during past 2-3 decades, there was an exponential rise in prevalence. So even that study, they have found out the pediatric population with the current prevalence of 5 to 10%, which is a very, the high level. So you can see here, so what are the, the global prevalence? You can see, especially in the low-income countries like us, are affected very badly with this epidemic. So it's very important to discuss the treatment. So what are the data from Sri Lanka? So more than 1/3 of our population are already affected. And if you think that the value is lower than the global prevalence and the less than in the South Asian and the East Asian countries, the personal and financial could be very, the detrimental to our country. Because what we know is at least more than half of Sri Lankan middle-aged elderly adults in urban areas has at least ultrasound evidence of fatty liver disease. So it's very common. So in addition, NASH cirrhosis is the most common referral for LD in Sri Lanka. And in addition, it is the most common cause for rejecting potential donors for LD in Sri Lanka. So it is very important to discuss this disease entity in detail. So this is study done by Prof. Anurag Dasanayak and team. So what they have found out, the NAFLD prevalence in adults is more than 30%, with a slightly predominant in female group. But they couldn't find any difference in prevalence between ethnic groups. But they found that all the metabolic risk factors was independently associated with NAFLD. So this study, the incidence and the risk factors done by Prof. Niriyal and team. So what they have found out, the annual incidence of NAFLD was around 6%. And they have found that in addition to the metabolic risk factors, there is a tendency of association of, there is a genetic preponderance. So we have seen in our practice that there are some, the families which NAFLD is coming as a cluster. So it may be due to the PNPLA3 gene polymorphism. So as I said to you earlier, more than 1/3 of adults in Sri Lanka are already affected with fatty liver disease. Interestingly, if you compare the data between 2010 and 2020, there was a notable 30% increase in diagnosed cases of fatty liver disease across the country. So huge burden and to the society as well as the health system. So these are the demographic data of NAFLD in Sri Lanka. It's more prevalent among middle-aged individuals, with around a quarter of those aged between 42 and 60 been already affected. So if you compare the data from the other countries in our region, our prevalence is slightly higher than neighboring India and Pakistan, but lower than Bangladesh due to so many reasons. So these are the data from prevalence in Asian countries. So in the Asian population, it affects around a quarter of the Asian adult population with disease entity. So the highest figures are coming from China. About half of their population are affected already. And if you compare the Japan, so more than 1/4 of population has already affected. So again, the interesting finding was that if you do a biopsy on a NAFLD patient, more than 2/3 of them found to have more severe form, non-alcoholic steatohepatitis, because you know that if you see the natural progression, the quarter of the NASH people will lead to cirrhosis. So it's very important to discuss these in detail. So I borrowed this slide from Prof. Niriyal. He just want me to highlight the NAFLD disease burden in Sri Lanka. So if you think that our population is 22 million, so the adult population would be 14 million. And the NAFLD population is around 4 to 4.6 million, and the NASH population will be just about the 1 million. So you are expecting about 57,000 cirrhosis on regular basis. So you have to you are facing a big challenge in near future. So this is one slide about the special groups. So they have done a study among pregnant group, but they have found out that about 18% they were found to have NAFLD. And if you compare the other risk factors, like they are having a 2-fold higher risk of developing gestational hypertension and preeclampsia during their pregnancy. If you, even after controlling for other confounding variables. So you can imagine that what the burdens we are going to face. So the adolescents, yes, again about 10% of our adolescents group in Sri Lanka has got this disease. And if you, they all have got all the other metabolic derangement going with the fatty liver disease. So what about the liver transplant? If you think that if somebody comes with the chronic liver cell disease or the cirrhosis, the definitive management would be the liver transplant at the end. So prospective study conducted at Colombo North Liver Transplant Unit, that they have found more than 50% of patients referred for liver transplant had cryptogenic cirrhosis. And the cryptogenic cirrhosis is the leading cause for liver transplant in Sri Lanka. And another study, they found very low graft acceptance rate, which reflects the impact of NAFLD in the country on a newly started liver transplant program like us. So what are the data? So this is the data from my center. So up to now in Kandy Hospital, we have done 11 liver transplant, 2 pediatric and the 9 adult transplant. So 9 adults, all the 2 pediatric liver transplant, the indication was cryptogenic cirrhosis, what we thought due to the metabolic dysfunction associated steatohepatitis. So then out of 9, so about 4 has clear evidence of MASH, and the 4 has MET and ALD, which I have described earlier. Only 1 patient we have transplanted for the alcohol-related liver disease. So if you compare the figures, more than 80% of our recipients were having metabolic dysfunction associated with steatohepatitis. So if you want to describe about the donor assessment, even in the cadavers, so 1 had got a moderate to severe steatosis, all others had at least mild steatosis. So you can imagine. So we have, if you go for to find out the draft. So what about the live donor assessment? So we have assessed 18 live donors for which is so-called healthy, having low BMI, who are less than 50 years. Only 1 female, even she is also from rural area, has no fatty liver disease. All the others had MASH. In fact, getting the graft from them, we had to start treatment on them. So the possibility. So the picture I am showing here. So on your right hand side, so the 2 gentlemen who had the liver transplant last year from my center. So one of them already had got the steatohepatitis on transplanted liver. So you can imagine what is going to be the burden in our society. So if you want to discover about the causes and risk factors, I just want to highlight what the NAFLD is thought to be due to the high visceral fat deposition in South Asian. So they are lean and non-obese. What we know is that it is associated with higher incidence of insulin resistance and diabetes, and it's ensuing the complications. So unlike in the rest of the world, South Asian have a higher prevalence of lean NAFLD and non-obese NAFLD. So if you don't have the vigilant eye, they might diagnose it at their late stages when they get the complications. So it's very important to know about the risk factor. So this is a study done in my center, in my clinic. So we wanted to find out what are the anthropometry measurements to find out whether you can predict the development of the non-alcoholic fatty liver disease. I'm not sure whether you can see the figures here. So conventionally what we thought is the BMI would be a better predictor for the non-alcoholic fatty liver disease. But our data suggests that it's not the, if you compare the Western figures, it's not the same. So what we have found that the higher waist circumference are substantially more likely to have the NAFLD. So it signifies again the importance of abdominal obesity as a risk factor of NAFLD development. And we propose that the combination of BMI and the weight-height ratio provide the promising results rather than assessing the individual anthropometry to predict the level of the fatty liver disease. So it's an interesting finding. So we are going to publish this data very soon. So the causes and risk factors, so we all know lifestyle factors, genetic factors are playing the role in developing the fatty liver disease. So one word about the alcohol consumption. So what we know is excessive alcohol intake can lead to alcoholic fatty liver disease. And even moderate alcohol consumption can exacerbate non-alcoholic fatty liver disease. So we have to advise our patients regarding alcohol consumption even in non-alcoholic fatty liver disease. So risk factors, yes, so the 70% of diagnosis cases being linked to excessive consumption of sugary beverages and processed foods. So that is very important in the preventive aspect. And the 45% of obese individuals diagnosed with fatty liver disease. So these are the common risk factors, but I have observed a lot of people with fatty liver disease who are having the high hematocrit level. So I had designed a study to find out association between non-alcoholic fatty liver disease and hematocrit. So it was a comparative cross-sectional study. It's a still going on study. So I just want to present the preliminary data which I have got this month. So you can see there is a linear relationship between the hematocrit and the fatty liver disease. So you can see that the level of the fatty liver disease, so it indicates the fatty liver level when it increases it with the level of the hematocrit level. So the message here is if you get a patient with high hematocrit, we should always look for whether they are having any fatty liver disease. So I'm going to, probably hopefully end of this year, I will be able to present all the statistics and the final conclusion. So we need to collect some sample, we need to get some subjects for the study. So diagnosis, yes, it remains largely underdiagnosed and undertreated. And it's usually an incidental diagnosis, as I said earlier. So if you get a patient with transaminitis or the abnormal imaging, you should always look for other secondary causes by doing the non-invasive liver screening. So gold standard would be the liver biopsy. But in our setup, we have got facilities for liver elastography and the FibroScan, which is a non-invasive test to rule out advanced advanced fibrosis in the fatty liver. So because if you detect early, it improves the treatment outcomes and it enhances quality of life and it reduces the healthcare cost and the burden to the society. So at the moment, what we are currently practicing as a screening tool, we get patients as a population-based screening, and if we do the clinical assessment, if you find anything, we can just go and do the basic liver test and the ultrasound to find out whether they are having any underlying fatty liver disease or through the awareness program. So these are the current screening practices in Sri Lanka. So I just want to highlight that the screening methods here. So the symptoms, you know that basically most patients with NAFLD remain asymptomatic. But sometimes you do get patients with abnormal signs and symptoms like hepatomegaly, acanthosis, or the splenomegaly. So when it comes to the complicated level, you will get all sort of complications like here, I have presented here, so which may be too late in the definitive management. So what are the potential complications? Sometimes our patients might come with upper GI bleeding, or the spontaneous bacterial peritonitis, or the encephalopathy. Rarely, which is not very uncommon, to get the hepatocellular carcinoma in the fatty liver disease, or sometimes they might present with the acute kidney injury. So I just want to highlight the association between the cardiovascular risk and the NAFLD. So this publication was from American Heart Association in 2023. So they suggest and they highlight that the NASH is a contributor to a marker for increased atherosclerotic cardiovascular risk. And it can be considered a risk enhancer when cardiovascular risk is assessed in a patient. So what they suggest that if you get a patient with a fatty liver disease, you always have to look for whether there is any underlying cardiovascular risk, because up to now what we know is that the most common reason, the mortality in a cirrhotic group is due to the underlying cardiovascular disease. So you have to always look for cardiovascular risk factors if you get a patient with the fatty liver disease. So the public health impact, it may be I can discuss on these topics. So it may be due to the burden of healthcare system, because they need frequent medical visits, they need hospitalization, sometimes they need ICU care. So if you talk about the resource allocation, they need, we have to allocate the extra resources such as personnel, equipment, or the medications to challenge this the epidemic. And they need long-term management. Because these are chronic illness. So we have to allocate some funds for this as well. So the economic impact, it may be direct cost or the indirect cost. So even social impact. So if you do get a patient with a chronic liver cell disease, mostly due to the fatty liver disease, so there are a lot of stigmata, and there are a lot of discrimination because they can't participate the social event like this. So we have to concern about these aspects as well. Because we know that if you think about the family perspectives, so family members are the often caregivers for our patients, and that there is a financial strain, and that they have to, there are disruption in their own lives, on their the loved ones' well-being. So these are the aspects which we have to think about if you want to manage these patients. So if you want to compare with other common liver disease, we have to give more weight on the non-alcoholic fatty liver disease. So because suppose that if you get a patient with the chronic hepatitis B at their late stage, you know that if you do early screen them, you can do intervention. And if you get a patient like hepatitis C, now it's curable, so you know that if you intervene them early, you can treat them fully. But unlike in fatty liver disease, because it's a multi-system disease, you need multidisciplinary care to manage these patients. So if you do get a patient, the early intervention, multidisciplinary care, health education, all are important in management of these patients. So the treatment and management, so that is to be dealt with Dr. Sumedha. So I'm not going to discuss about treatment and management, but rather I will talk on this topic. So the challenges in management of fatty liver disease, because we all know, so the access to healthcare facilities is not very, not very good in our setup. So particularly in rural areas where only 40% of patients have access to specialized care like hepatology. So the healthcare infrastructure, so Sri Lanka has the highest density of healthcare facilities per capita. Unfortunately, resource allocation for liver disease management remains limited. So it's a challenge again to manage these kind of patients. What we know is that lifestyle-related disease like diabetes and hypertension, they have implemented a very good public health campaign, but specific policies targeting MAPLD are still in the nascent stage. So that's what our society is trying to do a program like this to make awareness to prevent this epidemic. So the prevention strategies, so it may be public health initiative like implementing policies to regulate alcohol consumption and discourage tobacco, or the vaccination program for these patients, and the community awareness program, because we know that if you detect them early, we can treat them fully and before it goes into the irreversible state. And as a healthcare professional, we should educate our patients about lifestyle modification to maintain a liver health, because then only we can direct them for screening and counseling, and we can discuss about the risk reduction strategies. So I don't think that as a government, the policymakers, they can't challenge this as alone. So we need some help from the other organizations like the NGOs to help our patients. So again, to highlight that this is a multidisciplinary teamwork, so we can be the leaders to the society to manage the fatty liver disease, but still we need other supports like a primary care physician, nutrition, and the transplant surgeon, maybe so on. So as a society, so we always look for other regional collaborations like our neighboring countries. So this is the clinic which we are regularly holding in our center. So this is the post-liver transplant clinic held in last month in our center, so to discuss about post-transplant and the listed patients. So we always do share our, share knowledge with our neighboring countries' experts. So they used to come to our centers to discuss about our patients, and because if they are having the more experience, because we are just starting our program in our country. So just to highlight again the future policy recommendation, we have to make a more weight on to develop the surveillance system to monitor our patients before they go into the irreversible state. And again, to recommend that we need the policymakers to prioritize liver health promotion and the access to affordable healthcare service, and make an equitable distribution of resources for liver disease like in other non-communicable disease. So I think that's what I want to tell you. So the take-home message from my talk, that as I said, fatty liver disease is growing health crisis in Sri Lanka. And the key risk factors include the other metabolic risk factors like obesity, diabetes, sedentary lifestyle, and unhealthy diet. Because what we know is that the fatty liver disease is the liver component of the metabolic syndrome. So MASH can lead to severe complications like cirrhosis or the liver cancer. So the government is implementing national strategies and public awareness campaign, but still we are getting a lot of challenges. So the early detection through screening program is crucial. That's what I want to highlight. So we have to make sure we should establish a screening program. I'm sure that our president and the society will be leading to that to come that in reality. So we have to advise our patients regarding healthy lifestyle and the support initiative to combat this epidemic. So thank you very much. So I must thank President Professor Madhuri Niriyalla, Professor Anurad Dasanayaka, and my trainees and my colleagues to get this data and to conduct these researches in my center. Thank you very much.
Thank you very much, Dr. Chandra Piyaratna, for that comprehensive presentation on fatty liver disease. And ladies and gentlemen, our next speaker tonight has completed his MBBS from Faculty of Medicine, University of Peradeniya in 2011 with a second-class honours degree, and has completed his postgraduate training in Medicine and Gastroenterology and Hepatology, MD Medicine, PGIM, from the University of Colombo, and also has received the European Specialty Certificate in Gastroenterology and Hepatology from the Royal College of Physicians in the UK and European Society of Gastroenterology in 2022. And now, ladies and gentlemen, please join me in welcoming Dr. Sumedha Udumalagala as he shall present to you Turning the Tide, Optimizing the Current Management of NAFLD.
Thank you. Good evening, everyone, and thank you, Dr. Chatra, for that excellent introduction to the current burden of metabolic dysfunction associated fatty liver disease in Sri Lanka and the South Asian region. And my task is to continue on optimizing the current management of metabolic associated steatotic liver disease. So I will stick to the word MASLD from there onwards. So very recently, we have a new ESL guideline came out, which make our life easy in diagnosis of metabolic dysfunction associated steatotic liver disease, as well as its subgroups. So it gives you a very useful algorithm. And if you are one of your patient is coming with any evidence of steatotic liver disease in the way of incidental ultrasound scan or any liver biopsy or something, and if the patient is having one or more of any cardiometabolic risk factors, it was discussed earlier, like high BMI, more than 23 in Asian population, and or the waist circumference more than 94 for males and more than 18 females, and type 2 diabetes or pre-diabetic stage, blood sugar, high blood pressure or hypertriglyceridemia or low HDL. One or more of these cardiometabolic risk factors with evidence of fat in the liver. So then we have to just assess how much alcohol he is taking. If this it is a non-alcoholic or the patient is taking a mild amount of alcohol, it is less than 20 grams for female and then less than 30 grams per day in males, then you got a patient with metabolic associated steatotic liver disease. And then if the intake of alcohol is not mild, whether it is more than mild, like 20 to 50 grams per day in females or 30 to 60 grams per male, then you got MET-ALD, metabolic and ALD, metabolic associated liver disease with alcoholic liver disease. Then there are several other subcategories where I am not going to discuss much. Then the pathogenesis. So after tremendous work over many years by a lot of experts, researchers and clinicians interested in fatty liver disease, now we got a better understanding of the pathogenesis. It is too complicated and there are a lot of interconnecting mechanisms, genes and lot of receptors involved and cytokines like this. But to make the things easy, so what actually happens here is there's an energy intake exceeds metabolic needs of a person. So there are genetic risk factors, there are metabolic risk factors or environmental risk factors which leading into this exceed energy intake, and it will lead to hepatic de novo lipogenesis and increase free fatty acids. So the increased free fatty acids, they exert increase production of triglycerides and VLDL and deposition of lipid droplets in the hepatocytes, as well as they make lipotoxic lipids. So they are very inflammatory, and also they are they make insulin resistance. The insulin resistance in the driving force in the metabolic liver disease as well as its progression. So the genetic risk factors. So it has, now we know that there are several genetic polymorphisms as well as some genetic mutations like PNPLA3 and TMS6SF2 gene and MBO87. These genetic mutations will make a person prone to get metabolic liver disease and progress into cirrhosis. And also there are several loss of function mutations like CIDB and HSD17B13. This mutation will make you protective and it will prevent a person developing and progressing into cirrhosis. But the thing is that though we know many about this, our control over this is near to zero. We have nothing to do about that. But we have two other major risk factor areas where we can have a very good control over. It is the metabolic risk factors, the obesity, which was nicely discussed in the previous lecture, and the type 2 diabetes or pre-diabetic, hypertension, hypertriglyceridemia, low HDL, high insulin resistance, and high CRP levels. Apart from that, there are several endocrinological conditions like PCOS, polycystic ovarian syndrome, hypogonadism, hypothyroidism, and GH deficiency, which also associated with development and progression of the metabolic disease. And on top, and apart from that, obstructive sleep apnea, it's also associated with development of insulin resistance leading to metabolic liver disease. And the environmental factors, the unhealthy dietary habits, lack of physical exercise, and excess alcohol. So why these things are important to know? Because we can have our management strategies and we can use this knowledge to make our management strategies. So I think if you have time to listen to the recent discussion with Prof. Madhul Niriyalla recently, and he clearly mentioned, as well as Dr. Chadhar also clearly mentioned, that the prevalence of metabolic liver disease in pediatric population is in rise. So if we want to do something to prevent this disease, we have to start it early. So we have to target the younger population, school, universities, or youth organizations, and we have to educate them, and we have to encourage them, and we can use the use of a lot of social media platforms and short video platforms. We can use them to make awareness on this metabolic associated fatty liver disease. And then we can encourage them to have healthy dietary habits, maintain healthy BMI, and engage in regular exercise and physical activity, and to avoid alcohol. So the next step is early detection. So why the early detection is important? So it was clearly discussed in the previous lecture as well, where to some extent the disease, the metabolic dysfunction associated fatty liver disease, or MASLD, is to some extent is reversible. So having just steatosis and steatohepatitis and is reversible if you detect it early and if you intervene at the correct stage with the correct intervention. When it goes beyond advanced cirrhosis like F3, F4, and then the decompensated cirrhosis and hepatocellular carcinoma, then there's no way of coming back. So how we can do and achieve this? So we have to educate and empower the primary care physicians, general practitioners, and all other non-GI or non-hepatology clinicians to detect and intervene these patients. And the national-wide population screening still is not recommended, but still we have to take all the opportunities presented to ourselves to detect them. So you will always see patients with risk factors like obesity, alcohol excess, metabolic diseases like type 2 diabetes, hypertension, dyslipidemia, and positive family history. So once you come across this type of patient, always try to do something more and assess them. So why? So why we do this? Because the MASLD increases the all-cause mortality, and it's the cardiovascular mortality and is the main reason for death for patient with just MASLD without significant fibrosis. Once the patient reaches to a stage where the F2 fibrosis and beyond, then the liver-related morbidity and mortality increases. So the left side graph, which was a population-based cohort study, it shows if a patient just fulfilling the criteria for metabolic liver disease or the MAFLD definition criteria, then the all-cause mortality and the cardiovascular mortality rate rise exponentially. And how can we optimize our care at primary level or non-gastro setup? So there was a very easy 3-step setup protocol developed and has been using all around the world by primary care physicians and non-GI physicians. The first step is if you come across a patient with steatotic liver disease who fulfilling the criteria for the MASLD, then just use the simple non-invasive test, what we biomarker or clinically based non-invasive test, what we call the FIB4. So the FIB4 score is very easy to use. It is easily available and readily available in your smartphone at your fingertip. So it only needs the patient age, ALT, AST, and the platelet count. When you give this data to the software, then it will give back your score. If the score is less than 1.3, it means this patient is having a very low risk of having a significant fibrosis. So this type of patient will need lifestyle modifications and lifestyle and dietary interventions. Depending on the patient's risk factor, the number of risk factors, then we have to take the further decisions. But if the FIB4 score is more than 1.3, then this patient is having a high risk to having a significant fibrosis or the cirrhosis. So then we have to refer this patient to a specialist, the gastroenterologist and hepatologist, for the second level of non-invasive tests, which are imaging-based non-invasive tests. The vibration control transient elastography, or as you know, the FibroScan. Or then there are two other methods like MRI, MRE, and the MRI related depend imaging basis as well, but these are not freely available at our setup. So, and there are few other important highlights we have to know that if the patient is having a low FIB4, but if the patient is having more than one metabolic risk factors, then this patient need risk assessment every year. And the other thing is that if you come across a patient with suspected advanced NASH or discordant non-invasive test, this type of patients should be referred to a specialist for further evaluation to look for secondary causes for steatosis and other things. And also, this type of patient might need special management and further diagnostic evaluation. And the first degree relatives of patient with NASH cirrhosis should be counseled regarding their increased individual risk and should be offered screening for advanced hepatic fibrosis. These are the highlight points. And the next slide, what are these non-invasive estimations of hepatic steatosis and fibrosis we are talking about? So there are two main categories, the clinical and laboratory-based biomarkers. These are very easy, which can be used in our primary care stage, where the FIB4, the NAFLD fibrosis score, and AST platelet ratio index, or what we call APRI, and the ELF panel. So the FIB4 is out of this. The FIB4 score is highly validated and easy to use, and it was recommended to use in the primary care settings. So as I explained before, it only needs the patient age, AST level, ALT, and the platelet count. And the second level of non-invasive tests are the image-based. They are the VCT, or the vibration control transient elastography, or as you know, the FibroScan. And it is recommended as a point of care investigation because it is very easy to perform. And the MRE-based elastography, or MRI PDFF, or proton density fat fraction levels, the MRE and MRI PDFF are more accurate than the FibroScan, but they are not available readily. So they are only be used in the research setting. So we have to stick with the FibroScan. The important thing we have to understand is that although the standard ultrasound can detect hepatic steatosis, it is not recommended as a tool to identify hepatic steatosis due to a low sensitivity across the NAFLD disease spectrum. So the treatment modalities, what we have. So the baseline, or the foundation of management of MASLD is the liver protective healthy behavior, so the lifestyle interventions. So the optimal care of the patient with NAFLD requires a multidisciplinary approach. So the first thing, we encourage them to having a weight loss. So it has been well documented and research proven that a weight loss is associated with the histological improvement in NAFLD. So if you can lose at least 3% from your baseline body weight, if you are obese and overweight, and if you can lose at least 3%, then you can achieve improvement in your steatosis. But if you have ballooning steatohepatitis or inflammation, then you have to go to a higher value of weight loss, like up to 7%. But if you want to reverse your, if you want to try to reverse or some improvement in your fibrosis stage, then you have to go for up to 10 to 15%. And so, but the problem is that we can set this goal, we can give this instruction to the patient, but achieving this weight loss is not very easy. So it has been well documented that only less than 10% of people achieve these weight goals at the end of 1 year of intervention. And even fewer than half of this population will maintain the desired weight loss for after 5 years of intervention. So we have to work on that. So what recommendation we can give? So it is exercise regimen for at least minimum of 150 minutes of moderate intensity or 75 minutes of vigorous intensity aerobic exercises for a week, which should be spread over at least 5 days a week, and during that you should achieve a target heart rate of at least 60 to 70% from your maximal heart rate. And if you can engage in resistant exercise more than two days a week, that will be optimum. And what exercises you can introduce to them is depending on the patient tolerability and likely. So then it could be brisk walking, jogging, rhythmic aerobic exercises, swimming, cycling, or attending to the gym. So why this physical exercise is important? So this US-based study, which was expanded over 25 years, it has clearly shown at any level of BMI, if you can engage average phase walking for more than 3 hours per week, it could prevent 25% of your liver-related deaths. So, and the reduction of liver fat is also proportionate to the intensity of your exercise interventions. And the interesting thing is that the physical activity interventions improve your liver fat, inflammation, and fibrosis, even in the absence of a weight loss. So you have to encourage everyone to engage in exercise. Then the dietary modifications. So the excess calories, excessive fructose consumption, regardless of how much energy you are taking, and excess saturated fat, refined carbohydrate, and sugar-sweetened beverages are all associated with obesity and NAFLD. The Mediterranean diet is often recommended to patients with NAFLD based on its associated improvement in cardiovascular health. So it has an added benefit on cardiovascular health, as well as reduction in liver fat. And the coffee consumption. We are encourage people to drink at least 3 coffee a day, which has a better benefit on liver fat. So the Mediterranean diet pyramid. So if you can look at this can, if you can study this, you can give a better instruction for your patients to what to eat and what should reduce. And the complex whole grain starch and green vegetables and olive oil and milk and dairy products are encouraged to eat. And the red meat and processed food, they are discouraged to eat, should be less than at least 1 serving per week. And this diagram will give you a better understanding of what should you advise to a patient to how they can rearrange their diet, their food plate. So the half of the food plate is usually with non-starchy vegetables. So all varieties of vegetables except potato and sweet potato like starchy vegetables. And part of the food plate should be with starchy vegetables or the whole grain like brown rice, multi-grain bread, or whole meal pasta like things. Then the part of the food plate should be with protein. Protein products are what we encourage them to have: fish, seafood, and legumes like things, and also the poultry and eggs they can have with tofu, along with tofu. But red meat should be less than 1 serving per week, or should be avoided. And what you have to advise for your patient to do and not to do regarding their food plate, they should include many vegetables as you can have, and eat 2 to 3 pieces of fruit per day, and use extra virgin olive oil if you are affordable, and grainy breads and cereals, include herbs and spices, legumes, and eat fish or seafood at least more than twice per week, and choose white meats like chicken and poultry and eggs, and include moderate amount of regular or low-fat diet. What you should avoid: reduce red meat, processed meat, sugary drinks, packaged and processed food, saturated fat, and alcoholic drinks you should avoid. But we have to be very careful, because a lot of psychological barriers can impede the implementation of a successful dietary and exercise plan. So involvement of health psychologists and dietary clinical nutrition doctors and dietitians would be very helpful in these type of scenarios. That's why I earlier mentioned that the multidisciplinary approach would be the best. And now the emerging area, the role of bariatric interventions, endoscopic and surgical interventions to achieve weight loss. So it is now rising trend, and there are well set indications for that: BMI more than 40 irrespective of metabolic comorbidities, and BMI 35 with metabolic comorbidities. And there are a lot of varieties of bariatric procedures, endoscopic like intragastric balloons and duodenal mucosal resurfacing, and also the endoscopic sleeve gastroplasty. But and also there are gastric bypass surgeries like true and Y bypass surgeries. So this type of bariatric interventions has proven they can resolve NASH, improve hepatic fibrosis, and induce sustained weight loss up to 30%. And resolution of NASH without worsening of fibrosis also occurred in 80% of patients at the end of the 1 year following a bariatric intervention. So we have to identify, you have to identify the correct patient, and you have to refer them for these procedures. And then the next interesting thing is the pharmacological options. So not so long ago, we used to say there is no FDA approved medication for NASH. But luckily, now we have only one. So it is what we call resmetirom. So I will talk something about this resmetirom soon. And there are also some other available options. There's the vitamin E 800 units daily and 5-glutathione 30 to 45 milligram daily. Both of these vitamin E and 5-glutathione improves steatosis and NASH, but it doesn't have any activity against the fibrosis. In addition, the vitamin E reduces the liver-related mortality and mortality in cirrhosis as well. And GLP-1 receptor agonists like liraglutide and semaglutide, which was also recently gained much attention due to its effect on weight reduction and the positive effect on the reducing liver fat and the resolving the steatohepatitis. And again, both of these medication doesn't have a much activity against fibrosis. And the SGLT2I SGLT2 inhibitors, they will also improve steatosis and steatohepatitis, but their action on fibrosis is minimal. So a little bit more about the resmetirom. So it is oral administered once daily, liver targeted thyroid hormone receptor beta selective agonist. Okay, so this medication is shown reduce ALT, AST and gamma GT levels, and also it has shown positive effect towards reducing liver fat steatosis and also showing trends towards reducing the fibrosis. And on top of that, it also has other positive effect like reducing atherogenic lipids. It reduces LDL cholesterol levels as well. And then when we have evidence from previous trials for vitamin E and the pioglitazones, both vitamin E and pioglitazone will reduce AST/ALT levels, and vitamin E more than pioglitazone will reduce the histologic features of NASH, but neither of them will not improve fibrosis. And on top of that, the pioglitazone will improve the insulin resistance, but in the expense of weight gain. So it is long-term use for that benefit is questionable. Then the lean trial, which explore the effectiveness of liraglutide on NASH and steatohepatitis, and it also shows there was good histological resolutions of non-alcoholic steatohepatitis as well as, but it doesn't have any effect on fibrosis. Then semaglutide, another GLP-1 receptor agonist, and among patients with NASH fibrosis, once daily injection of 0.4 semaglutide is superior to placebo in NASH resolution. But there's no significant difference in improvement of fibrosis stage. And apart from that, there's something we have to know, that metformin, ursodeoxycholic acid, DPP-4 inhibitors, statins, and silmarine. So we were used to we are using this medication for metabolic in patients with correct indications, but they are also well studied in the NASH, but they do not offer a meaningful histologic benefit. And what are the new drugs on the line? So we have few drugs, and the fascinoid X receptor agonist obeticholic acid, which has taken a much attention recently due to promising results in reducing steatosis, steatohepatitis, and also trends toward reducing, improving fibrosis in Flint and regenerated trial. But it is still not got the FDA approval for NAFLD because of the safety concerns. Then there's another drug, what you call saroglitazar. It's a dual PPAR agonist, and it's the phase 2, phase 3 trials are ongoing, and it also is showing good results on improvement in steatosis and steatohepatitis. So possibly in near future we will have these things in the market. Then the allogenic fecal microbiota transplant. So it is still in the research stages. It has both true and false evidence. Is still but we don't have enough evidence to give a recommendation on that. And the most important the other aspect is the optimal management of metabolic diseases. So the MASLD, as we already discussed many times, that the MASLD increases the cardiovascular death, and it is the most common cause of death among only the MASLD patients is the cardiovascular. So all patients with MASLD has to screen for CVD risk, and it should be aggressively managed. So the management of diabetes in the presence of NAFLD. So we have to target for the best glycemic control. So we have to target for HbA1c less than 6.5 if there's no any contraindication for that. And also we have to encourage clinicians to use the medications with added benefit on NAFLD, like GLP-1 receptor agonist and SGLT2I inhibitors, depending on the affordability and availability, of course. And the other thing is the metformin, sulfonyl ureas, and DPP-4 inhibitors. You can continue these medications, but you also have to know that they don't have any added benefit over metabolic liver disease. And other thing is the atherogenic dyslipidemia management in presence of NAFLD. So it depends on the cardiovascular risk stratifications. So if the patient is having a very high cardiovascular risk, then you have to achieve LDL-C goal less than 100 and triglyceride goal less than 150. And if the patient is having a very high CV risk over extremely high CV risk, then your targets are much more less. But the most important thing is to identify that the statins are safe in steatosis and steatohepatitis, as well as compensated cirrhosis. But we have to be very careful, or you have to discontinue when you are, or we have to take individual based decisions if you are going to use it in decompensated child C cirrhosis. And the other thing is that you have to reassess the patients whether they are achieving the intended goals. If they are not achieving intended goals of lipid management, then you have to add, or you have to intensify the statins, or you have to add a second agent like ezetimibe or PCSK9 inhibitor, like this. And if the triglycerides are more than 500, so you have to offer fibrates, and you can also give treatment grade omega-3 fatty acids. And if your triglycerides are in the range of 135 to 499, less than 500, then you can emphasize on your diet and or you can add icosapentaethyl. And the management of hypertension in the NAFLD. So you have to have a very aggressive management. You have to have a systolic blood pressure less than 130 and the diastolic blood pressure 180. And so it's safe to use ACE inhibitors and ARBs as the first line medications. And also you can use calcium channel blockers, beta blockers, and thiazides as a second line. But you have to be very careful if you are using ARBs and ACE inhibitors in decompensated cirrhosis, and better to avoid. So the key points is we should not neglect associated medical diseases. We have to treat aggressively, and we have to encourage clinicians to use drugs with added benefit for NAFLD, like GLP-1 receptor agonist and SGLT2I inhibitors. And statins are safe in NAFLD, NASH, and compensated cirrhosis, but you have to take individual decisions, or you have to be very careful if you are going to use it in decompensated cirrhosis. And apart from that, optimal medical management of hypertension, hypothyroidism, GH deficiencies, and polycystic ovarian syndrome, if present, is very, very important. So the take-home messages is the MAFLD prevalence is very high. It was nicely described, and should take every opportunity to identify risk of patients. And please follow the FIB4. It is easy to use. It's a FIB4-based protocol in primary care, and refer to specialist opinion accordingly. Then always look for associated metabolic and environmental risk factors and intervene early. That's where we can intervene. And the lifestyle modifications form the foundation of MAFLD management. And main killer in MASLD without fibrosis is cardiovascular disease. And once the patient develops F2 fibrosis or above, then the liver-related morbidity and mortality in the rise. And always try to choose drugs that have added benefit on MAFLD when managing diabetes. And again, statins are safe in NAFLD and should be guided by the CVD risk. And MDT approach is always better to optimal management of MAFLDs. Okay, thank you.
Thank you very much, Dr. Sumedhu Udumalagala, for that valuable insights. And now, ladies and gentlemen, we have listened to many vital discussions and presentations on NAFLD, MAFLD, and so on at the International NASH Day 2024. And now we shall open up the floor for a question and answer session. So we'd like to invite all of you to please make use of this opportunity and pose your questions to our speakers here today, who will be more than happy to elaborate and clarify by providing you with answers. So please, if you do have a question, raise your hand and an FM mic shall be passed on to you. The floor is all open, and please make use of this opportunity to pose your questions now. If you do have a question, please put your hand up.
If I can ask one question from Chatura, that was an interesting study on the increased hematocrit and fatty liver disease. I presume you excluded smokers?
Yes.
Yeah. So what is the sort of pathophysiological mechanism or the association between that increased hematocrit and fatty liver?
So actually I did a thorough literature survey on this. Unfortunately, I couldn't find any literature. And that's what I decided to do this. So what is the, I'm doing the research with the hematologist, hematology colleague in National Hospital Kandy. So what we were thinking, whether it is inflammatory driven conditions. So whether the one cause is doing maybe one etiology for the high hematocrit as well as for the fatty liver. So At the moment, what we are thinking, it's an inflammatory event, I mean, the inflammatory triggering. But yes, as you said, that I have excluded all the other secondary causes for polycythemia, like primary polycythemia and the secondary polycythemia. But I couldn't present all the data here. So we usually even, we are planning to extend with the bone marrow biopsy even, because we do in our setups basically the JAK2 mutation, which we all have done for these subset of patients, and we have excluded the other, I mean the not smokers and so on. So basically we have excluded, so we are thinking to extend even to the bone marrow biopsies, yes.
We know that most of the NAFL patients, even in our setup, 80% are overweight or obese, and they have obstructive sleep apnea. Did you look into that?
So yes, we have excluded that, and we have done the sleep study to exclude that set of patients, yes.
Thank you.
Thank you very much, Professor, for your questions, and also thank you very much, Doctor, for your answers. And once again, we'd like to direct the opportunity to our audience here to present your questions to our speakers here on stage. Yes. Give us 1 second as an FM mic is now coming towards you.
Is there any association of vitamin D for treatment or management of these conditions?
So actually, what we know so far, most of the time in our cirrhotic groups are deficient of vitamin D. Unfortunately, we don't have free test to, the pre-test to detect that whether they are deficient. So as far as we know is that there are no, I don't know that the Prof will have any other opinion. So our cirrhotics groups, because they are deficient, we used to give conventionally, because I know that there are some patients who have got even toxicity of vitamin D because of we are giving irrational. But at the moment, what we know is that they are, most of the time they are deficient and they are more prone to get fracture risk. Anything you want to add, sir?
I don't know whether you have endocrinologists in the audience. In general, it's sort of contradictory that Sri Lankan population, it's not uncommon to find vitamin D insufficiency or deficiency. Most of us are actually insufficient because we don't go out in the sun anymore. Actually, we are indoors most of the time. So there is no clear studies that show that there is a direct association between vitamin D and NAFLD so far.
Thank you very much, Professor Niryanna and Dr. Chatra, for your clarifications. And we shall move on to the next question now.
This question to Dr. Sumedha. We all know that repeatedly we listen that the weight loss is the key to reduce the risk of progressing the NAFLD into the fibrosis. But again, the same slides we see, because the failure rate is, like success is less than 10%. So I think knowing the treatment, but still we are facing the same trouble. Have you get any any propaganda or anything to increase that percentage of rate reduction and get the success? Because rather than searching for many options, any idea about any thing to promote the weight loss?
Yeah. So as you are correctly saying, actually the achieving the weight goals are very limited. It is not in in our society, but all over the world is like that. So that's why we are introducing this the multidisciplinary approach actually, which is so much of the time it lacks. Not only on the here, but everywhere the multidisciplinary action is not very common. So just giving a goal is not will work. So we have to get together with the primary care physicians, the hepatologists, and the clinical nutrition doctors and dietitians, and even the physiotherapists and psychotherapists as well. And that's one way of addressing this problem. The other way is that, as I mentioned, is the bariatric surgical intervention. So there are a set of indications, set of indications, and also the trend is now increasing to offering this type of interventions for them. I think in Sri Lanka also the procedure rates are now going up.
Thank you very much, Dr. Sumedha. And we'd like to see a show of hands of who. Yes, we have one more question coming in.
Are there any studies to support intermittent fasting for NAFLD?
The basis is that when we are giving a recommendation for the dietary recommendation, actually there's no statistically significant difference between what is the method you are using, what is the method we are using for weight loss. So if you are achieving at least a calorie deficit diet, less than 500 600 kilocalories per day, and also you are eating healthy, like Mediterranean type of diet, and low on fructose, low on carb, and refined carb, and more vegetables, then you will have your targets. But there's no statistically significant difference between whether it is intermittent fasting or something else. But we prefer these Mediterranean diets because of this added benefit over the cardiovascular health.
Thank you very much, Doctor.
To that, what is important is weight loss. How you achieve it is okay. Whatever the patient prefers, a proven type of diet is okay. What is more important is actually what we should emphasize to our patient is this hypocaloric diet. They should take at least 500 to 600 calories less than what is the requirement. And these weight loss targets also, there should be a little bit of clarification, because the weight loss target of 7 to 10% is for the overweight and obese. Now we have about 20% of NAFL patients who are non-obese, who only have central obesity. Their BMI is normal. So what do you tell to them? So for them, it's 3 to 5%. So half of the overweight and obese. So for overweight and obese, the weight loss target is 7 to 10%. For the normal BMI people, the target is half, 3 to 5%.
I have few doubts to clarify. I'm a cardiologist, and now if you look at the liver pathology and the coronary artery disease, and the people who have fatty liver, will it change the synthesis of pattern of lipid profile with them? That's one. Second thing is, as the patient develops fatty liver in advanced liver, will the cholesterol synthesis come down with the liver?
Yeah, if I can answer, yeah. So atherogenic dyslipidemia is what is associated with MASLD. So that is high triglycerides and low HDL and high LDL. So that's the association, and there is some evidence that actually with advancing liver fibrosis beyond stage 4, with the development of compensated cirrhosis, and especially decompensated cirrhosis, actually the cholesterol levels do come down. And we also commonly see that actually.
And very frequently we see people who are with coronary artery disease with statins, bit of elevation of gamma GT and a bilirubin with normal ALT AST. Do you have any connection with the fat? At the same time, of course, the ultrasound picks up with the grade 2 fatty liver. Will there be any connection with these, or is it because of the statins?
So you don't have to be scared of using statin in fatty liver patients, even with a degree of fibrosis, even up to compensated cirrhosis, as very correctly Sumedha mentioned. Statins are very, very safe in liver disease. That's one thing. This gamma GT elevation, even in the absence of alcohol intake, is not uncommon. We commonly see AST elevation more than AST. That's the classic pattern. But there can be some degree of gamma GT elevation. That is not uncommon. But if you have a bilirubin elevation, there is something else going on, and that also probably is Gilbert's, if the patient is healthy. But you should be careful in attributing the raised bilirubin to Gilbert's only because they might have significant fibrosis and they might be just starting to have cirrhosis also. So you must have a comprehensive elevation for bilirubin levels in a patient with fatty liver. But the gamma GT is quite normal. It can be an association, and you should always inquire very carefully about alcohol intake.
Very much, Professor. And we have the opportunity for a few more questions. Yes.
It was mentioned that semaglutide and liraglutide, both of which are GLP-1 antagonists, is beneficial in the management of NASH. Now, both these medications were initially developed for treatment of diabetes. My question is, can they be used in a non-diabetic patient who has NASH?
Thank you, sir, for the question, but the answer is no, because this GLP-1 agonist is still not recommended for the NASH. So it is recommended for the diabetes with NASH because of the added benefit over the development steatosis and the steatohepatitis. But for people with NASH without diabetes, answer is no.
Thank you, Doctor. And any more questions, ladies and gentlemen? We'd like to see a show of hands if you have any further questions.
Just one comment, I think, just to clarify, NASH trials require two endpoints. One is the improvement of steatosis without worsening of fibrosis, and also the improvement of fibrosis without worsening of steatosis. So most of the drugs that were suggested, from vitamin E to pioglitazone to these other anti-diabetic drugs, have shown improvement of steatosis, but they don't improve the fibrosis. So that's why they are not FDA or any other drug regulatory authority approved. So the only drug which does both improvement of NASH and improvement of fibrosis without worsening the other is resmetirom. And it's prohibitively expensive for our patients. It's just coming in USA, and they're also having problems prescribing the drug for their patients also because insurance companies are not approving because it's so expensive. So it's going to take ages for it to come here. So what is left for our patients is just healthy lifestyle and target weight loss.
Any further questions, ladies and gentlemen? Well, with that, we believe we can close the question and answer session now. Thank you very much, Professor Niriyala, Dr. Sumedha, and Dr. Chatura for your clarifications, and thank you very much to our audience members who posed those vital questions. And with that, ladies and gentlemen, we cordially invite Mr. Deekita Bandara, Senior Business Manager at B&G Health, to speak a few words.
Good evening, ladies and gentlemen. The chief guest tonight, Dr. Asela Gunawardena, Director General of Health Services, Ministry of Health, Sri Lanka, Professor Madhunil Niriyalla, President, Sri Lanka Society of Gastroenterology, Dr. Nandana Dinamitra, Joint Secretary, Sri Lanka Society of Gastroenterology, all the senior doctors and distinguished guests. First and foremost, on behalf of P&G Health, we would like to thank each and every one of you for sparing time and for attending today's program. So as explained by the two experts, prevalence of non-alcoholic fatty liver disease and non-alcoholic steatohepatitis has drastically surged in recent years. Also, the disease has spread beyond developed countries to low and middle income countries. However, alarming stats reveal NASH will affect 357 million people around the world by 2030 with a very high prevalence rate. So International NASH Day was inaugurated in June 2018 by Global Liver Institute to raise public awareness on this concealed global epidemic. So we, PNG Health, is a socially responsible multinational entity which markets some well-known pharmaceutical brands in Sri Lanka. As an MNC, our intention is to support upgrading of the healthcare sector of Sri Lanka within the defined compliance framework. Also, we are delighted and privileged to support this critical global health priority for the second consecutive year along with Sri Lanka Society of Gastroenterology. Lastly, I will take this opportunity to thank the two eminent speakers, Dr. Sumedha Udumalagala and Dr. Chathura Peyaratna, for their thought-provoking lectures, and the President and the Council members of Sri Lanka Society of Gastroenterology for joining hands with us for this important forum today. So whilst thanking the invited dignitaries for their presence, we would like to invite all of you all to enjoy the rest of the evening. Thank you very much.
Thank you very much, Mr. Digita Bandara. And now, ladies and gentlemen, we'd like to present a few mementos to our speakers this evening. And to present these tokens of appreciation, we'd like to invite Dr. Asela Gunawardena, Director General of Health Services, Ministry of Health, Sri Lanka. If you could kindly step forward, sir. Thank you. And the first token of appreciation goes out to Dr. Chathura Lakmal Peyaratna, Consultant Gastroenterologist at the National Hospital, Kandy. And the second token of appreciation goes out to Dr. Sumedha Udumalagala, Consultant Gastroenterologist, Teaching Hospital, Kalutara. Thank you very much. Thank you very much, Dr. Asela Gunawardena, for doing the honors. And now, ladies and gentlemen, in order to propose the vote of thanks, we'd like to cordially invite Dr. Nandana Dinamitra, Joint Secretary at the Sri Lanka Society of Gastroenterology.
Good evening, everyone. As we draw this insightful and significant event to a close, it is my privilege and to extend a vote of thanks to all of you who have made today's NASH Day program a resounding success. First and foremost, I would like to express our deepest gratitude to our chief guest, Dr. Asela Gunawardena, Director General of Health Services, Ministry of Health, Sri Lanka. Thank you, sir, for gracing us with your presence and sharing your valuable insight, despite your incredibly busy schedule. Your support is invaluable to us. And our sincere thanks to our esteemed speakers, Dr. Chathura Lakmal Peyaratna, Consultant Gastroenterologist at Teaching National Hospital, Kandy, for your thought-provoking lecture on silent threat and growing burden of fatty liver diseases in Sri Lanka. Your insights have certainly inspired us to act together to mitigate the effect of this silent killer. I would like to thank Dr. Sumedha Udumalagala, Consultant Gastroenterologist at Teaching Hospital, Kalutara, for your enlightening lecture on optimizing the current management of NAFLD. Your guidance is crucial in turning the tide against this disease. Thank you, Sumedha. And we are deeply grateful to our generous sponsor, PNG, for their unwavering support. I need to mention a few names. Mr. Ushan Piris, Digita Bandara, Dinushan Serasinghe, Indika Pereira, Mrs. Doris Pereira, Nuan Samira, Shanushka Chaminda, Shamila Dilukshana, Ravindra Vittasinghe, Dushantan Subramaniam, Namageethan, Taraka Sandaruan, Shehan Alavatta, Hadi Ruben, and Malinda Dilshan. Thank you. And your contribution has been instrumental in making this event possible and successful. Otherwise, without your help, we can't do an event like in this caliber. Thank you very much, PNG team. And I would like to thank all the invitees, guests, and participants for attending this event on World NASH Day 2024. Your interest and presence, despite your busy schedules, have been vital in making this event a success. And our appreciation goes to management and the staff of the Shangri-La Hotel, Colombo, for their excellent support in arranging the logistics for this program. And special thanks to our audiovisual team, Impressed. We are very impressed about your work, Nalina and his team, and our compere and the photographers. Thank you very much. And I will fail in my duties if I do not mention this name. A special mention to Prof. Madhunil Niriyalla, President of Sri Lanka Society of Gastroenterology, for single-handedly organizing this event. Thank you very much, sir. We are incredibly proud and fortunate to have you as our leader at SLSG. Thank you very much, sir. And lastly, I would like to thank the council members, and the well-wishers of Sri Lanka Society of Gastroenterology. The knowledge we have gained today will undoubtedly help us to change the practice of managing NAFL and tackle this growing global burden more effectively. And I now invite all of you to join us for the fellowship dinner. Thank you, good night, and have a pleasant evening.
Thank you very much, Dr. Nandana Dinamitra. And just like Dr. Dinamitra mentioned, we'd like to extend a big thank you to our sponsors for coming on board this International NASH Day 2024. And ladies and gentlemen, we have few quick messages from our sponsors.
One touch can bring back the will to live. One smile can spread cheer. One nudge can be someone's strength. Because healthcare is human care. And it does not limit itself to just medicines. It is about understanding pain before painkillers, temperaments before treatments, and the person before the patient. This is made possible by a science far superior than any other. A science that goes beyond treating illness to creating a world of care and wellness. The science of human care. We know. Because this understanding is the core of our innovations and the crux of our legacy. It gives meaning to our medicine. It inspires us to create world-trusted, highly recommended, irresistibly superior quality products that help empower patients and consumers live healthier and more vibrant lives. Healthcare with human care. PNG Health, the science of human care.
Non-alcoholic steatohepatitis, abbreviated as NASH, is a hidden epidemic and a progressive form of non-alcoholic fatty liver disease (NAFLD). Currently, non-alcoholic steatohepatitis affects over 115 million people globally, posing a significant burden on healthcare systems. By 2030, it is projected that approximately 357 million people will be affected by non-alcoholic steatohepatitis. In Sri Lanka, the prevalence of NAFLD or NASH stands at a staggering 32.6%. indicating that approximately 1 in 3 individuals is affected by this condition. NAFLD often goes undetected and underreported due to the subtle nature of its symptoms. Prioritizing early detection and intervention strategies can significantly help prevent further complications and consequences. Patients with hyperlipidemia, diabetes, and obesity are at a higher risk of developing NASH. These patients should undergo comprehensive screening for risk assessment due to their significant overlap. Patients can be screened for fibrosis by calculating app-based FIB4 score on basis of elevated liver enzymes in both diabetic and non-diabetic patients. Early identification is the key. If left untreated, NASH can result in the development of cirrhosis, progressing to liver cancer. In severe cases, liver transplantation may become necessary. Though the first line of treatment for NAFLD and NASH is lifestyle modification and achieve 5 to 10% weight reduction, very few abide by it. Vitamin E has emerged as the next primary treatment option to treat NASH. The landmark PIVENS trial demonstrated that taking vitamin E 800 IU per day for 96 weeks leads to significant histopathological improvements. Specifically, it showed improvements in steatosis, inflammation, and ballooning. Additionally, this regimen was found to decrease serum aminotransferases, further highlighting its effectiveness. Clinical studies have consistently shown that vitamin E supplementation can lead to significant improvements in liver health for individuals with NAFLD. These improvements include reductions in liver fat, inflammation, and fibrosis, all of which are key factors in NAFLD progression. Let's work against NASH. Identify early. Avoid late-stage complications. Improve quality of life. Be the change. To bring the change.
P&G Health presents Be the Change. Numbness in fingers or toes is a result of damaged nerves that don't transport signals correctly. Neurobion with vitamin B1, B6 and B12 helps relieve numbness and tingling. A combination of neurotropic B vitamins helps maintain healthy nerves. Vitamin B1 promotes nerve activation. Vitamin B12 supports the regeneration of nerve fibers. Vitamin B6 is essential for the transmission of signals. Say yes to healthy nerves to keep in touch with the things you love. Neurobion is the world's #1 B vitamin brand with a combination of neurotropic B vitamins B1, B12 and B6. P&G Health invites you to be a part of our initiative to improve patients' quality of life through early identification of diabetes-associated complications. Be the change to bring the change.
And with that, ladies and gentlemen, we formally conclude the International NASH Day 2024, hosted by Sri Lanka Society of Gastroenterology, supported by P&G Health. Thank you very much to our eminent speakers this evening, and also thank you very much, ladies and gentlemen, for being here with us this evening, as well as for your active participation. And with that, we invite all of you over to the fellowship and dinner. Enjoy the rest of the evening. Thank you very much.